Has everyone been corralled from coffee break and et cetera? All right. So thanks everyone for sticking out through this, and thanks to the speakers for the great sessions this morning. And we have one new person, Dr. Weiss, who will be adding his additional thoughts to this. So I think, in order to kick this off, and please feel free to interrupt with any questions at any point, as well as panelists with questions amongst yourself. But I wanted to start off with, we heard some mention of some of the other approaches like carbon proton where radiotherapy may be going. So my question is, coming from someone who is a biologist, no background in radiation or physics really, what else is there either enabling that may be like nanobiotics or other physics-driven and machine-driven things like the carbon or the proton? What other approaches might be the future of radiotherapy, and what degree do they represent a potential challenge, say, for nanobiotics versus representing an additional opportunity that the nanoparticle could be added onto? So I don't know, maybe we'll start with you, Dr. Rabin.
Yeah. So you can hear me. So some other really interesting areas that we didn't talk about today that hold some potential promise that would include a couple things. One is spatial radiation, and the other is flash radiation. And my radiation oncology colleagues know about this. So flash radiation is giving ultra high dose, super rapid delivery of radiation within seconds. And some of the preliminary data with this is very, very intriguing in terms of the way it also may change the microenvironment, but more importantly, it seems to not initiate DNA damage activation, so you don't get the DNA damage in the normal tissue. So this is an area that's moving forward in the future in regards to looking at this ultra fast delivery of radiation. And again, it's almost scary when you look at what they're doing. But it's very, very intriguing, and that may be something worth exploring and contrasting to protons or photons or typical hypofractionated radiation. And then the other one is grid radiation. I think you guys may be doing this at Chapel Hill too, where you're actually, it seems counterintuitive, but you're not treating the whole tumor. You're poking holes in the tumor. So it's a grid, and that grid type radiation may actually be very, very interesting in terms of its potential combinations with Nanobiotix compound, your lead compound. And so, and the way grid radiation may work may also be very intriguing in terms of how that might change the tumor microenvironment differently than treating homogeneously the entire tumor. So when you talk about advances in radiation oncology, I think we've hit the limit with when we talk about delivering high dose radiation in terms of 70 gray. We're not going to push it to 80 gray or 90 gray or any of that kind of baloney. We're getting more and more sophisticated with our delivery. I don't know how much more we'll get, but I think this potentially is the next frontier from a physics standpoint that may interact biologically with what we want to do. So I'll leave it at that.
So given the physical mechanism of action, and Laurent, you mentioned it in your talk, and the potential, at least in theory, to have this added onto anywhere and any type of radiotherapy one might do, is there anything that would limit the potential utility of the nanobiotics approach?
No, I don't think so. I mean, what I like about this is its wide applicability and the fact that it's potentially so complementary to so many different types of tumor sites and different drugs, immunotherapy, and again, I was really, really happy to see the lack of toxicity in the injected sites, both in sarcomas and in head and neck. I honestly was worried about the head and neck area and what would happen, and I'm really have to say I'm kind of a skeptic like Tanguy, and I was really happy to see how safe this compound is and how, again, potentially complementary it is to anything else we do. So it won't take away or prevent us from giving something else that's absolutely critical. It will amplify what we're trying to do without increasing the side effects. And that's to me exciting.
Yeah, any of the other many radiation oncologists on the panel want to amplify on that? Or?
Well, can I ask just one question?
Yeah.
Do you think protons are more immunogenic than than regular radiation? And then could R3 be combined with protons? Is there anything to think it would interact differently?
I mean, I'll let you answer this first if you like.
So I think actually there's some data that shows they're not more immunogenic. So there's not a lot of data. So I gave this talk on it 2 weeks ago, and I gave a completely blank slide on the rationale of immunogenic effects of protons.
I could give that talk too.
And I said, so this is the data. And I said, maybe you think I drank too much and I didn't prepare, but no, this is the data, right? We've done a very bad job of that. There's a little data, and I don't think it is, but with a particle on it actually could be quite different. One other comment on the trial thing is, historically how we do drug trials, it's this setting. It's breast, triple negative, and in this setting, and we do the study. But what's powerful if we can do things agnostically across the tumor board? And so there was a recent PD-1 approval for MSI high tumors, right? Regardless of tumor type, and that got approved, which is very profound because it works regardless. And I think this could be potentially the same way. Radiation is used in 70% of all patients, and even though we're talking about trials, it should, it'd be great to be able to get an approval for using this with radiation when you can't meet dose constraints. And that's how we get protons approved, right? Protons cost twice as much as photons. No insurance company wants to pay for it. I make a dose volume histogram. I say, look, I'm going to protect the rectum or the heart by this much if you allow me to do it. And if we could say, I'm going to give 40% less radiation because the particle's on board, that would be very powerful.
Okay. That is a really, really good comment. I hadn't really processed it that way before, and you just saying that really hit the light bulb for me. That, for instance, in lung cancer, I mean, and head and neck cancer for sure, we are really constrained sometimes. And sometimes it's really a matter of a choice of, okay, well, we're going to have to back off the radiation here, because if we don't do that, we're going to kill the optic nerves, or we're going to do this or that. So that means we know we're going to compromise probably tumor control because we don't want to blind someone, or we don't want to prevent them from ever swallowing again. And that's a real fine edge that we walk on as radiation oncologists. And so the way Jim just said that just really hit me that, my goodness, if we could say, okay, well, we can't give 70 gray, or we can't give 40 gray in 5 fractions because we're going to really violate some of our dose constraints, and really going to potentially hurt the spinal cord or the optic nerves or the swallowing apparatus or the submandibular glands, whatever. We can go down by 20%, or we don't have to do that because these nanoparticles are going to give us the bang for the buck. That's a really, really important thing for our field. For anybody who goes through the sweat and the pain of what we go through hour after hour of planning one patient, and how much time we put into the planning because we don't want to hurt the patient while we're still trying to cure the patient. That's a really critical comment to me. I mean, you said it in a way I hadn't thought about it before.
I'll add to that I'm treating someone right now, and we had this conversation a few weeks back where I was like, well, I'm probably going to blind you if we try to cure you on that side. And he said, well, I'll take the blindness in that one eye. I want to be cured. But can we do that without blinding someone?
Yeah. And you guys are head and neck, I'm lung, but every radiation oncologist faces this no matter where they're at. If it's in prostate, then you got the bladder and the rectum. Pancreas, you have the duodenum. Everywhere we treat, there's some structure that keeps us from going as aggressive as we want. So this is the balance, and that's what residency is all about, teaching people how to be aggressive when it's appropriate, but not cause the toxicity.
Well, we're giving a lot of secrets out to our medical oncology colleagues because they think we just sit down in the basement and push a button, and they have to do the same thing with creatinine clearance and figure out who's going to get cisplatin each day. But it is true. It's a very stressful thing that we go through sometimes, making these calls on patients. So this potentially is a game changer in that regard, I think. So.
Right.
I'm going to add a little bit to the microbeam part too, the grid therapy. So we do have some preclinical data at UNC, and so far it seems like it's interesting, at least in the mice, that with the really high dose grid therapy, where you're giving sometimes 200, 300 gray just to really thin lines, which is really crazy, but you're not treating in between. They are starting to see kind of increased immune response with the grid therapy, potentially more abscopal effect, whereas the uniform dose therapy is better at treating the local tumor, but not having as much of the distant and immune kind of sting type reaction. And so if you combine the nanoparticle potentially with grid therapy, maybe you can enhance the lower dose that's in between the high dose and still treat the tumor appropriately while creating that distant effect too. So I think that's pretty promising.
Yeah.
This Oh, go ahead.
Please go ahead.
You know, the fundamental nature of this conversation to me, I agree with all of this, but it sort of ignores a point that I think may be worth bringing about. This is a conversation that we're having about how this is going to enhance radiation, right? Building upon a standard paradigm. And I come back to the cartoon slide of Henry Ford, and people are looking for faster horses, and he gave them a car. This to me, a lot of what got me excited to get involved is that this is, to me, more of a car than it is a faster horse. I don't see advances in radiation oncology being the threat here. I see this, you know, bread and butter patient that I see in my head and neck cancer clinic, right? So I see lung as well. We don't super specialize quite as much as in Texas. So I see lung and I see head and neck. My generic lung cancer patient presents with de novo metastatic disease and is referred to me for systemic therapy. I need to get drug everywhere, otherwise I'm playing whack-a-mole and not helping the person. I involve my radiation colleagues in such a patient. There's a painful bone mat or something, some place where local control is needed, but it doesn't provide traditionally a survival advantage. In head and neck cancer, it is very, very common. First off, my generic patient is a locally advanced patient we're trying to cure. But many of my incurable patients are local only. And this is radically different than the way we think about a lot of other cancers. And to me, really key to understanding what's exciting here. It's very bread and butter for me to see a patient who has no surgical options, no radiation options, in other words, no local control options, and yet no metastatic disease. And it's extremely frustrating. It violates our basic principle of cancer therapy, which is local problem, local treatment, aimed at cure. Distant problem, distant treatment, not aimed at cure. This violates that. This is an exception in all of oncology where this is bread and butter. And this offers that patient, theoretically, the opportunity at not only avoiding the systemic toxicity of our drugs, not that we ever hurt people, but also perhaps an actual attempt at cure. This is much more car than faster horse.
Yeah, it was
I would like to echo this. I was about to make the same comment. Radiation, forgive me for this. I mean,
no, don't ask forgiveness. Go there. Go there.
It is relatively stable. There's nothing that's going to be disrupted. Grid therapy might be slightly better. Protons might be slightly better. But what we're talking about is potentially something that's like log-folds different, tenfold, ninefold more. So it is very, very different. And the same is true, to be fully honest, What about radiation sensitizers? There's no progress, none at all. We just have 2 trials now that failed. That cetuximab is not better than cisplatin. Some people think taxanes are better. Maybe they are, but marginally. There's nothing that's really making our radiation better. We don't even know what the right radiation sensitizer is. So I would say that both radiation, while there's gradual, slow improvements, and new technologies might again be slightly better, there's no improvements of radiation sensitizers. This is something that's potentially disruptive, and I think the comparison is, we are trying to make the horses slightly faster by breeding them over time, but this is potentially a car. A car has to work, and obviously it took some time, but in principle this is very, very different, and I agree with Jared's comment 100%. That's why I got excited, and I think that's why you also said this is something worthwhile doing.
Good.
Sorry.
No, it's just weird to see 2 medical oncologists so excited about radiation.
Well, it's not the radiation we're excited about. It's not the radiation. It's nanobiotics. It's not you. It's not you.
No, but it's
not you. It's them.
I just feel really warm. I feel
in other
really
words,
warm and cuddly right now.
So it's not the nanoparticle that enables the radiation. It's the radiation that enables the nanoparticle.
But that's a disruptive way of thinking, I think, and that's something that radiation oncologists have to adapt to as well. And I think that's important.
Right. So we're going to leap right now into more of the immuno-oncology aspects, because that's my favorite part. I mean, I know that from the kind of the analyst side, there's kind of
with the radiation.
Yeah, there's the near-term benefit and approvals of the programs that they have ongoing, but clearly there's a lot of additional potential upside and certainly fervor, if not furor, around the immunological aspects of radiation, and in particular what the nanobiotics program can do. So I want to go back to a couple of things were mentioned, but something that Jim and also you, I think you were talking about, and that is the importance and potential value, but also the challenges of local delivered therapy. This is given intratumorally. Stings, TLR9, a number of the oncolytic viruses are certainly given, and there are probably other. You can also, there's a lot of benefit, sadly passed. Holbrook Court was looking at smaller doses locally delivered of various types of agents, checkpoints and co-stim agonists. So there's a lot of things one can explore. Maybe start with you, Jim, thinking about, how does one start to sort through and say, well, the next best combination. So we've got radiation and we've got this nanoparticle. What would be the next most logical, best bang for the buck combination? Or can we not even answer that question or start to answer that question now from kind of basic biology and theory? Do we just need to do a bunch of experiments?
Yeah, so, that's the part that the immuno side that gets me most interested about this compound, because if it's local control, that's great, but then you're going to be doing a certain thing in a certain direction with it. But if it becomes systemic, then it's very different, and we can take it in a different direction, combine it with different stuff, and take it into stage 4 patients. And to me, that's the part we're challenged on. We're really not great on the systemic side on the radiation, and it hasn't been our world, but we're moving more in that direction with a lot of data coming out that for aggressive oligometastatic. So, what's the logical thing to try it with? And I think the first thing we go forward, and I was glad to see that you got the PD-1 in there, because that's what's getting approved everywhere. It's kind of becoming a standard. We had some data that the particle increases the PD-1, which is great. So I think those are the first ones to try. I look at a lot of the agents. I've probably explored about 50 agents so far in our models, and everything's not perfect in a mouse. It's not great for Tregs, but I think PD-1's okay. I don't think it's the best thing for immune and for radiation right now. I actually think the old CTLA-4s are actually better. Most of the preclinical data all comes from CTLA-4, and then everyone, it's a confusing time right now because these drugs they're working on cells we don't focus on, right? We really don't care about the tumor anymore. I don't anymore. When I radiate and do a treatment, I don't even care what the tumor is doing. I care about the MDSCs and the macrophages and the CD4s and what's going on with them and their activation. So there's a lot of new drugs that'll come out that may even synergize and be better with this one. So the way I kind of think about it is we know where this, you already have a bit of a head start because some drugs I don't even know where they fit in, right? And so I don't know if the drug should be before or after, but this one we kind of have a clear idea of where this needs to fit into this slot. And we know then the PD-1 needs to go out here afterwards. And so there's a rich opportunity now to see what else can complement this and make this even better. And then the nice thing is, as we've done combinations with CTLA-4 and PD-1, we've had tox. We've had problems with colitis and different things like that. So it's harder to do more and more. This is something you can cleanly add. Shouldn't give you any more tox because it's a locally injected one. And I think that's going to be the fun thing and the opportunity going forward is seeing what to combine this with.
Are you working, just a quick question, and I want to ask others, are you working on any of the next generation CTLA-4 agents, either the blocked ones or the depleting ones, or?
Yeah.
Okay.
So we have non-fucosylated IPI, which hits Tregs 1,000 times more. There's a neat one from Isotonics. They have a coating that they put around the antibody, and so the antibody doesn't work until it gets by the protease of the tumor, and then it gets degraded, and then it works. So the antibody will only have the effect locally. So there's a lot of interesting stuff that's coming out. It's really hard to keep up with, actually.
So I want to talk about in this, I think Jared and Tengi and Jim and others can talk, but this issue of the abscopal effect. Clearly that is potentially quite powerful. Talk a little bit more about, how strong the data are, not only with this specific program of nanobiotics, but with other types of approaches, because there's certainly, with our clients in industry, there's a lot of confusion about how real or not. A lot of people throw out, we're going to see, and particularly NUCOs, early stage biotechs, we're going to demonstrate abscopal effects. But I think it would be useful for everyone to get a little more understanding of kind of how real, how challenging, particularly what we've seen to that degree in humans. I know TVEC to some degree have shown that, but not so. Maybe start with you, Jared.
Well, so I think whenever you use the word abscopal at a conference, half the room sort of cringes or makes a funny face, right? It's, at least with radiation, I think it's more talked about than seen, right? It's not the world's most common phenomenon. So I think your question now actually links quite well to the last one in thinking about combination, right? So if we believe there's something going on beyond the local effect, and I'm intentionally being vague for the moment, then in asking what's the right combination, you have to think about, well, what mechanism? What are you actually seeing to think about how are you going to synergize and what's promising? And when I see a sting-like flavor, I think of personalized vaccines. In our hands, we've never seen a more effective adjuvant, at least in murine studies, than sting agonists. for some of our personalized vaccine efforts. And so that's the first thing that I think of. If you have an effective adjuvant, then add a vaccine.
So I will add my comment to abscopal effect, which is I would show the usefulness of the abscopal effect in routine clinical practice is an empty slide. Just like there is nothing. Abscopal effects clinically play no role because we can induce them. And once in a lifetime, you might win the lottery. And we all, I don't think anybody here has won the lottery. I've never seen a abscopal effect, and I've tried. Essentially, it does not exist in clinical practice. However, they have been reported. But radiation is consistently unable to induce abscopal effects. If something really did that, it would be great. However, we've only seen it in mice consistently. So I would be very, very cautious. The other point I think we should make is that every time that PD-1s work, there's a gamma interferon response. In fact, it correlates almost perfectly. A working PD-1 shows a gamma interferon response in the tumor. And so when I saw these first data of what R3 was doing in sarcomas, a tumor that inherently doesn't have gamma interferon responses, inducing this, I made that connection right away. This looks like exactly what a PD-1 inhibitor does. And when people talk about abscopal effects with radiation plus CTLA-4, the reality is you're giving a systemic agent. It's not necessarily an abscopal effect. So I'm much more of a believer that R3 is more like a training for the immune response, and then the checkpoint inhibitor will do the work. And so I'm a big skeptic about abscopal effects. Sure, when they come, that's great, but I believe in a systemic agent and local training of the immune system, and then I think it could work. And so I believe that the combination with a checkpoint inhibitor, a treatment that actually does induce a gamma interferon response, that's a perfect combination. That's going to be synergistic. And I also like the idea of killing tumor. And you use something as non-specific as radiation. Just kill some tumor. That's a good thing because that opens up the tumor for the immune response, and R3 will only make the radiation stronger. So I think it's a very nice combination, but I do believe the checkpoint inhibitor is essential. I like the comment about CTLA-4. CTLA-4 may be very attractive biologically. It's a very good agent. I think PD-1 is definitely a reasonable start because it's so ubiquitous, it's going to get approved everywhere. But I do believe that potentially adding a CTLA-4 may be important. We talked about competing technologies for radiation. I'm not sure that there is that much as we talked about, but obviously the big challenge is, and maybe the biggest opportunity for R3 is to become an immunotherapy. There's a lot going on obviously there, and I think the competing approaches there are STING agonists, TLR9s, oncolytic viruses. And I made, when I thought about this, I said, well, what's in my mind more applicable, more readily available, and maybe more promising? And I thought that R3 was a very good bet, and I still hold, and I'm very happy with this choice that we are doing this trial with R3. STING has been in large part discovered, developed at University of Chicago. We'll see how that plays out. But I'm a believer that actually R3 does exactly what it does in patients. We see gamma interferon response. We actually see STING activation and maybe several other things. And so I think clearly this is the right approach. There may be others in the future, but just to put things into perspective from the systemic perspective.
So I have to, of course, push back on that a little. So I've treated about 500 patients with IO radiation. That's actually all I've done for the last 5 years. I don't treat anyone who's not with IO. So I've treated a lot of patients, and the abscopal response is hard to get, for sure.
How many out of 500?
So I can show you. So I've done
That's the answer.
I have three trials with 100 patients each. And what we're doing, we're randomizing to prove it, because you can't prove it if you get abscopal response because it wasn't the immune therapy. You can't prove it. Yeah. So what we do is randomize, and I take people who are already resistant to PD-1. And we have a new trick where we're doing low dose to modulate the stroma. And with that, I get 37%. I get 37% in about 40 patients that I've treated with this technique. But it is hard to achieve, for sure. And that's why we need more agents and combinations on top of it. But I'll give a different spin on abscopal. There's gross abscopal and microscopic abscopal. And so what I mean, so we have data in the lung world where we've randomized stage 1 between surgery and radiation. And there's less distant failure if you irradiate a tumor versus cutting it out. How can that be? How can you have less failure with radiation? And I think that's because we produce this immune response and you get less distant failures. And that's pre-checkpoints, right? So I can show you large European data and our prospective data that will show this. And so that's just radiation alone. And I think I don't think as radiologists we get credit for that. We don't get credit for the distant PFS spot that never came up because of the immune response. And I call that microscopic abscopal. This is, in the mice, this is very, very easy to achieve. So I have a big tumor here, a big tumor over here that I'm abscopaling, and I produce spontaneous lung mets. And the lung mets abscopal very, very easy because they're microscopic without stroma. The bigger the tumor is on the other side and the more stroma, the harder that abscopal is to achieve. And so I think if you take your particle and you hit everything with radiation, you will get this microscopic abscopal benefit. And I think that's very readily achievable. And we'll see that in the head and neck trials. You might have less distant failures. And to me, that's what happened in Pacific. Why Pacific worked so well, because you knocked out all the gross disease. But true abscopal, when it's gross disease, we're not as good as we need to be, and we need to be.
And I'm glad you mentioned that, because I was actually going to make the comment that I really think, it's more about, from the immunology, or the old, as they were called, tumor immunologist standpoint, it's more about getting that local activation of the immune system to be able to then translate into a systemic, and particularly get the immunosurveillance, so those memory cells are there to mop up or find those distant micro metastases, those particularly if they're quiescent or dormant, cells that are lurking who knows where or everywhere. So, Laurent, we haven't heard from you. You're sitting front and center, as you should be.
No,
Any comments about this
Fine.
discussion? Any thoughts or questions from?
Yes, many. I think starting with what's going on today in cancer therapy, there are plenty of approaches. And just like radiation, there is a potential for combination and synergies a lot. And adding our product in it will also allow different potential synergies. So in almost everything we see out there, even STIG agonists and so on, we see more synergies than competition. And we don't think that with one product we'll be able to cure cancer, obviously, but we see potential for combination in many things. So that's my first comment. And the other one is about the abscopal effect. I mean, I agree with everything that has been said, including the fact that sometimes it may happen, you just don't see it. It's not because you don't see something that it does not exist, but if you start looking for it, then you see it. And that's why I like your study about surgery versus radiation. And you see a difference between what's happening in the long-term follow-up of the patient. So, like I said previously, in biology, you just find what you look for. And what I like about what we do is we could help to redefine the concept of curing cancer patients. Just like the image of breast cancer, you're doing the things the wrong way if you want to exploit the immune system. Our wish is to, for example, go for every patient, find a small dose of radiation that will be non-toxic, adding our product to prime the immune system and to give enough of the local control you need, avoiding surgery when it's not a good surgery to be done, and had some modulating agent of the immune system. And with this, you could start with zero with every patient and provide a new way of curing patients. That's not an easy task because you have to go sometimes against many lines of treatment that are working, but I think on the long run, we could redefine the way we treat patients completely.
So, any questions? All right, let me push the button here a little further. And I say this in full disclosure because my question is going to be funny, given that we were just up at our client Neon Therapeutics yesterday. But it seems that with the potential of the appropriate radiotherapy combined with the nanoparticles, perhaps combined with a checkpoint given systemically, at least for now, perhaps combined with some other things systemically or locally, one could envision a situation where you would get the in situ vaccination and then ultimately get the release of those neoantigens, get antigenic spread, et cetera, without the need to go through all the trouble of potentially developing an autologous, individualized, neoantigen-based therapy. I'm playing devil's advocate here, so I'm throwing that out, and I want to hear people's kind of comments or thoughts about that. So since you're
making funny faces?
Yes.
So I think that you have to ask the question of how you believe that radiation produces an immune stimulating effect in terms of this. Do you believe that there's really an in situ vaccination approach where radiation induces presentation of new antigens that were not otherwise presented, or you believe that radiation is effectively an adjuvant that might, with that adjuvant, potentially amplified by the addition of something like R3. And this is a controversial question, but I think the evidence for increased presentation of neoantigens with radiation is weak at best. It's not a strong effect. We have seen recently that, at least in melanoma, and we've seen it across tumors and preclinically, that even with our so-so bioinformatics pipelines for predicting neoantigens, that we can elicit T-cell clonality that was not present before. Whether it's cytotoxic hasn't been proven, at least in published form, but we can. So I actually, I do see potential for that synergy here, but I see the role of radiation perhaps massively amplified by something like this product as providing the adjuvant, not as providing the neoantigen presentation.
I agree, and I'll expand on this. And again, I'm a bit of a cynic, and this goes back to Tom Gajewski, who, so the predictions are terrible. Trying to predict which is the right antigen that will drive.
Except our in-house pipeline. It's great.
Except
it's great.
the UNC one, which is really amazing.
So you get high CD8s over CD4s then?
But so predicting the right one is hard, and so the best strategy is to do many. Whether it's 5 or 15, you just try to make so many that you'll hit one that's right. But even if you hit the right one, if you go back to Steve Rosenberg, and when you ask them, you identify the right TIL and you give it and you start the fire, and then you measure again. There's epitope spreading, and the one that actually is driving, the clone that's driving the anti-tumor immune response, is usually different from the one you gave. Like making the prediction, even if you get the right prediction, in the end, it's something different. It's a different clone that's actually driving the immune response. So the whole idea of predicting is very challenging because it's a
especially when it's about the future.
Especially about the future.
But I've heard that
that's a great quote. And so Tom will always say, these approaches are nice, but nothing will ever equate what the immune system does. And so why not generate the right microenvironment with a checkpoint inhibitor? That's what he says. In this setting, it could be by generating, with radiation and a very special way of killing the tumor plus a checkpoint inhibitor, doing it in vivo. So I believe that's in my mind, a more promising approach. I mean, I could be proven wrong, and maybe these algorithms will get much better, but I'm still worried about the neon approach, the gridstone approach. These predictions are very challenging, I think, and I'm not sure that we're quite yet there, and I think there will be a lot of learning and a lot of trouble. I think doing it in the patient where the environment is perfect, where you definitely have all the right clones, all the right antigens, and letting the immune system do its very complicated process that's dynamic, in my mind, is a lot more promising. And that's why I think checkpoint inhibitors are great and work, and we just have to set the immune microenvironment right, and that's what I think radiation, and maybe R3 plus radiation will do.
Yeah, well, I set up an artificial binary system because I actually, I think I agree with you that there probably will be situations where exogenously supplying neoantigen is probably helpful, and others where. Dr. Raven?
I mean, I think it's more than just neoantigen release. I mean, just amplification of PD-L1 expression and amplifying the ability of the drugs to respond because of the radiation changing, cold tumor to hot. I mean, I think if you look at the Pacific study and the outcomes, there's some real critical data that was presented the other day. And that was, not only was there a decrease by 50% in local failure, but the time to distant mets expression was drastically changed, okay? So clearly something was happening from a micrometastatic standpoint in terms of expression. Now, could you do will you ever do a clinical trial of chemo alone, followed by checkpoint inhibitor in locally advanced stage 3 versus radiation? None of that's ever going to happen. But the fact that there was a change, and that was regardless of the high or low PD-L1 expression, outside of the ones that were less than 1% PD-L1 expression, there was a dramatic change in the local control, but it was a dramatic change in distant metastatic expression. We haven't seen those kind of numbers in lung cancer ever. Okay? So this is a game changer. So now the question is, can we do even better than that? And can some compound like this, in the locally advanced setting, we're not talking the metastatic setting now, the locally advanced setting, can that amplify it even further? So we're getting curves above 70 to 80% in stage 3 lung cancer, which are just curves we're just not used to seeing. And so I think that whole thing brings back around. We talk about neoantigen release, but I think we're overstating that part of why we're seeing benefits potentially, if that makes any sense.
So maybe in the interest of wrapping up, yes, maybe each of you in turn, we'll start with you, Dr. Shen, can just make any kind of closing thoughts or observations about these presentations today, what we've heard on the discussion, and the potential of the Nanobiotix program.
Just one other thing that hasn't really been brought up and is a little bit out there, but because I also treat pediatric tumors, one of the things that I think might be really interesting for this down the road is, for pediatrics, we always really try to decrease dose to normal tissues. And I know it takes a while to really introduce things in the setting with children, but if we can get something where it can become much more locally effective while we can reduce the dose to the rest of the normal tissues, I think it might be an area that could be really promising for this too.
Great.
Yeah, I guess I'll just say, right place at the right time, right? I mean, this is an interesting thing that by itself, it's probably not going to be enough to do the whole immune response and produce these great systemic responses, but you're at the right place at the right time. I mean, we've got all these new immune agents that are being validated, approved, and then we have all these things to work before and after them to make them even better. So it's just an incredibly exciting time for the immunospace in general. And I think that your particle is in a nice place to take advantage of that, right? So if you had just this particle by itself 20, 30 years ago, you're going to move the needle a certain amount. But the fact that you can take advantage of OX40s and Treg drugs and MDSC drugs to complement and get that fire started and then to push it a lot better is going to be a really great time for you guys. So,
great. All right, let's skip over you, Laurent, and we'll come back to you at the end so you can have the final word, Dr. Seward.
So I think it's great to have a radiation enhancer, but I think it's much more exciting that this is arguably one of the most exciting immunotherapy enhancing drugs, and that's really why I'm so excited about it. I think this is really an immunotherapy, and that's also why it works probably as a radiation enhancer, at least in part. So I'm very excited about that aspect, and I think that's, in my mind, one of the most promising approaches compared to some of the other intratumoral agents.
Right. Dr. Weiss.
So Shrek likened ogres to an onion, that there are lots of layers. Okay, that was funny in my head. Sorry, only David enjoyed it. But to me, this is a lot the same, right? So on the most mundane level, you have this radiation sensitization. And mundane as that is, I think it's actually a really big deal for all the reasons we've talked about, right? It can help a lot of patients in a very meaningful way. And then as you dig deeper, you get to this distant sting-like response that all of us on the stage are excited and nerding out about and have chosen to spend lots of time on, as opposed to other competing efforts that we potentially could be doing and are choosing to risk the lives of our patients on because we believe in it. But then when you get to that deeper level, you see us discussing and arguing about what the optimal combination is, right? Is it a PD-1 drug? Is it a personalized vaccine? I don't know what the answer is. I may be very wrong in my answer, but the discussion to me focuses me on the idea that this is a broad mechanism with a lot of potential for synergy as not being a one-off story, but a very expansive story with additional work later that could matter.
Great. Dr. Raby?
I'll make better jokes for the next time we do one of these.
No, my grandmother used to call me a Shrek, if I was causing trouble, because it's Yiddish for ogre. Some people don't realize that. Anyway.
I assume that's not your last statement on that.
I rest my case.
Could be. No, I think everything that was just summarized, I think is perfect. I would add that I'm very happy about the safety issues. I think that was absolutely critical. It's one thing to do with sarcoma, but it's another thing to show that in head and neck cancer. And that was really important. And I do think, for instance, just imagining in my head, in clinical trials in head and neck cancer, for instance, I honestly think that the 4 or 5 trials that are ongoing now with immunotherapeutics, many of them I think will potentially be positive in locally advanced disease. Wouldn't it be neat to have a trial of R3 plus radiation followed by immunotherapeutics versus chemorads followed by immunotherapeutics? Could we replace the chemo with this kind of agent that starts to fire in a different way and then gives the immune modulating drugs? Now we've decreased the toxicity considerably. We potentially reduce radiation doses or do it quicker, and now get to the critical aspects of checkpoint inhibition or CTLA-4 inhibition or things like that. So thinking down the road, those would be my visions for something like this, and those are paradigm shifting.
Great. Laurent, any
Yeah, a very quick one. I mean, usually it's me you're hearing talking about what we do and how we're going to change the world and everything. But today I was quiet because that's good to hear other people saying it. So thank you. And if you have any question, then just come to us and we'll be happy to discuss.
Great. Well, I thank the speakers especially, and thank you for attending. Thank you.